important for us to always be learning about. And I'm going to try to make this super practical. First of all, I don't get money from anyone. My wife gives me a very carefully calibrated allowance if I'm good. Otherwise, I don't get anything. And just a couple of reminders. Remember that the trauma patients that you take care of, remember, trauma is the leading cause of death in patients under the age of 45 and the fourth leading cause of death overall. And then if you look further at big killers or traumatic deaths in this country, you'll see that the number one cause of traumatic death are traumatic brain injury, various causes of hemorrhage is number two, and then multi-system organ failure that will usually occur in Dr. Christmas's shop in the trauma ICU within 24, 48, 72 hours is number three. So what I decided to do is talk about, I initially said three. We'll see if we can squeeze in a fourth. I'm going to talk about pelvic ring injuries, which is a particular interest of mine. We're also going to talk about aortic injuries, traumatic brain injuries, as I mentioned, and we'll try to finish with splenic injuries. So we're going to do this in a case-based format. We'll go one case at a time. So this is a patient who actually was seen here not that long ago, a 27-year-old in a motorcycle crash, which I think is important. You can see the pre-hospital vital signs. The patient is significantly tachycardic with a blood pressure of 106/60, alert, has cool extremities, so some signs of shock, and significant lower abdominal tenderness and pelvic tenderness on compression. So the team rapidly starts with diagnostic testing with some imaging, of course, always a fast exam, and then laboratory studies are sent off for diagnostic testing, and the patient receives a type and cross that I would say would be imperative in this case. And I'm just going to show you the patient's x-ray so we can get to the punchline. This is a normal chest x-ray in a trauma patient, and there are no significant injuries identified. Now, in contrary to that, this is the pelvis x-ray that you see that reveals a significant diastasis of the anterior ring of the pelvis or the pubis, the pubic symphysis, and this is going to have some major implications that we're going to talk about. And the patient has a normal FAST. So normal lung sliding, there's no fluid in the pericardium, and there's no fluid in the peritoneum. So the question then to this team is, okay, there you are looking at this x-ray, and let's say that you're a sender, so the patient's going to come here after some stabilization. What does your team need to be focusing on? Now, the reason that I think this is very important, if you go back to anatomy, remember that the pelvic ring is the strongest structure in our bodies. So the ligaments and the bony structures of the pelvis, they lend it incredible stability. And therefore, when you have a pelvic ring injury, the force that was required to do this is so significant that just consider this to be a major force delivery to the patient. And therefore, it's highly predictive of significant injuries. In fact, I just looked at this earlier this week with the help of the trauma service team. We've had at the CMC, we've had 14 deaths so far in 2025 in patients who had pelvic trauma. Now, in several of these cases, the pelvic injury was not their only injury and may have not even been their most important injury, but in several, as in the x-ray that you can see here, a patient, again, with a majorly disrupted pelvis, this is highly consequential for the patient. And if I'm looking at this x-ray, I'm the first person to see this x-ray, or we're looking at it together, I'm not going to ask myself who was on for ortho. I'm going to ask myself, when is this patient going to have cardiovascular collapse from ongoing hemorrhage? And then again, looking at this population of patients here at CMC, those 14 patients, albeit a small number, you can see here that 80% of them are male. The mean age was actually a little bit higher than I expected. And then also of high importance, the most common injury mechanism are motorcycle crashes. And this holds true to pelvic trauma looked at in many case series. So my advice to you, if there's an incoming motorcycle crash coming into your emergency department, that you think about pelvic injury before the patient even arrives. And in our series, of course, MVCs were the second most common. So we're going to walk through really a stepwise approach to addressing this, and what are the essentials that we need to do in the emergency department before the patient is transferred and ultimately after the patient receives definitive care. Really important to define the injury, begin aggressive resuscitation. We're going to talk about pelvic stabilization or pelvic immobilization, and then some more advanced resuscitative maneuvers and definitive hemorrhage control. So let's talk about how to classify these injuries. And there are a number of classification systems that have been described, but the most important for us to know is one that is based on the injury force vector. So from which side of the pelvis was the force inflicted? Then the second question for us to answer is, what does this injury pattern do to pelvic volume? Pelvic volume is really the space on the inside of the pelvis, and the punchline here is if the injury causes pelvic volume to go up, then that leaves space for hemorrhage. So us being able to do a careful appraisal of the initial plain film x-ray is critically important. And really we have three mechanisms here: lateral compression injury, which is the most common, followed by AP compression, that we often use the word open book when we talk about an AP compression injury, and a vertical shear injury. And now we'll look at some x-rays for each one of those. So most common is lateral compression. I want you to imagine that Mike Gibbs is crossing the street and there's a car coming straight towards me. And at the last minute, I will turn to try to avoid being struck, and I get struck on the left-hand side. So the force vector comes in from the left. My left hemipelvis is struck. What happens here is that you have a crush type mechanism, and this pelvic ring, this part of the pelvic ring rather, will be crushed inwards. And the hallmark, when you look at the plain film, the hallmark is that you have horizontal fractures through the anterior pelvic ring. You're also going to have a crush injury in the back that may be a little bit more difficult to see on plain films, but the vector comes in from the side. Now, if we look at this and you ask yourself, is pelvic volume right here where I'm outlining, is that the same as it was a couple minutes ago? Is it larger or is it smaller? I'll just say that it hasn't increased. So this injury pattern typically does not increase pelvic volume. So in most cases, but not all, hemorrhage into this area is may not be the primary problem. Again, looking at the film over here, you can see the tell on this x-ray is a horizontal fracture through the anterior ring. We also have some evidence of injury to the sacrum. The other clue here is that the full bladder is deviated to the other side. So lateral compression injury. Here's another one, lateral compression injury. The force vector came from the left. You have a horizontal fracture across the anterior ring of the pelvis, and this is going to shift over to the opposite side. Again, that's the most common injury mechanism, is lateral compression. The second is AP compression. And let's say that Mike Gibbs is crossing the street and I don't have time to turn, so I'm struck head on or in the front of my torso, and what that'll do is it'll pull the pelvis apart in the front. Now here, in contradistinction, again, here's the x-ray with a very significant diastasis of the pubic symphysis and a very profound increase in pelvic volume. So again, when you see this x-ray, I would say the most important thought in your brain should be action. There's a lot of things that we need to do to stabilize this patient, begin resuscitation, and prevent the patient from bleeding to death. And if left alone, that's exactly what's going to happen. So again, for you, for the sender group, what you do in your ED before this patient is ever transferred to a trauma center is absolutely vital and will be life-saving. Here's another AP compression injury, not quite as dramatic as the first one, but again, there is diastasis right here of the pelvis, and you can see some widening here in the back of the sacroiliac joint. The third injury mechanism is called a vertical shear injury, and this may be, for example, if I'm driving and I have my foot on the brake pedal and I hit a pole, and the force vector will go up my femur and pushes the hemipelvis upwards. This is also a very important injury because in addition to increasing pelvic volume, what happens here with a vertical shear injury is that you injure a large number of important vessels that wrap around the back of the pelvic ring. So a vertical shear injury is also extremely consequential and is associated with very high morbidity and mortality. Here's another one here with a binder in place where you have the left hemipelvis and the right hemipelvis. You can see that there's upward movement on the left. Again, that defines vertical shear injury. So going back to them again, so we have lateral compression, a couple here, AP compression, another one there, and then vertical shear. Now, I will tell you that I was always taught that to test for pelvic instability and to press on the pelvis, I would say rocking the pelvis is not really what we want to do now, because that can cause more hemorrhage. But the other message here, this is actually a patient that I took care of with Dr. Miles, who's one of the trauma surgeons. This patient had was very shocky, so was encephalopathic, and also had a devastated right leg. And when we examined her pelvis, there was no evidence of instability on physical exam. So I would just say, be careful with your exam. What you're trying to do is not rock the pelvis, but just look for pain or tenderness when you press down on the pelvis from the front or from the sides. Now, now that we've classified our injury mechanism, it's important to begin resuscitation, and this has to be very aggressive for the reasons that I mentioned. So what we're trying to do fundamentally is avoid what's called the death triangle that occurs with ongoing bleeding is acidosis, hypothermia, and coagulopathy. And we know that when the patient enters into the death triangle, this can cause major bleeding and irreversible shock. So a couple of basics here. Remember, catheter size is important, and simple things like inserting a larger French catheter, as you can see here. And I never thought I would actually enjoy looking at a physics equation, but as you can see here, with the same length catheter, the difference between the flow rate of a 20, 18, and a 16 gauge IV are very significant. So the larger the catheter, the better for us to begin our resuscitation. We also know that in 2025, crystalloid is out. Now, I learned when I was a resident many years ago to give 2 liters of crystalloid and then follow that by blood. But in a patient like this, unless you don't have blood available, I would go right to transfusion immediately, because we know with larger volumes of crystalloid that actually potentiates hemodilution and causes coagulopathy. Now, I think it's fine to start some lactated ringers, but I also would not delay transfusion in our patient who has signs of shock and a clear pelvic injury that with increases in pelvic volume. And then we know nowadays that really there are 2 choices in trauma resuscitation when it comes to immediate transfusion. If you have whole blood, there is some evidence that whole blood actually decreases transfusion requirements over time. If you don't have whole blood, be sure to balance your component therapy with not only PAC cells, but plasma and platelets. Now, in patients who predictably are going to have high volume transfusion, it's also important not to forget about hypocalcemia in trauma that has been shown to be associated with increasing mortality, and this actually decreases vascular tone. So generally, and whether you use 4 units of blood or 3 or even 2, it doesn't really matter to me. But I would say when you're getting to about 4 units of PAC cells, you want to go ahead and empirically give 1 gram of IV calcium chloride or calcium gluconate to the patient to stay ahead of transfusion-associated hypocalcemia that's been associated with significant changes in mortality. We also know that tranexamic acid that you give every day in the ED is going to be critical in this patient. So we're going to give 1 gram of IV TXA followed by an infusion over 8 hours. And also making sure that you're attentive to prevention of hypothermia in a patient who may be exposed, who may be getting cold fluids and blood product. So just keeping an eye on that during your resuscitation is really important. Now, the next step is, and I would say coincident step, not next, but coincident is going to be to apply a pelvic binder. And what we do when we apply a pelvic binder is we pull that pelvis that's open, we pull it down back to something close to its original anatomy, and this is actually going to tamponade bleeding in the pelvis. We know that most pelvic bleeding is venous, about 85%, and not arterial. So by merely putting on a pelvic binder, you're going to significantly reduce ongoing hemorrhage into the pelvic cavity. And we want to have this at the level of the femoral trochanters. I'll show you. This is our patient, the patient that we started with a binder, but this is the image on the left before a pelvic binder was placed, and the image on the right, I would say it's a little bit low, but the image on the right is, again, the pelvic binder applied. This only takes a minute to put on, and you can see there a significant reduction in diastasis of the pubis, and therefore of the anterior ring rather, and therefore a return of pelvic volume closer to normal size, and therefore tamponading of bleeding, and therefore improved mortality. And then just from a kind of a memory lane perspective, I'll just tell you that the pelvic binder was actually designed and patented by some folks that you know. There's the list on the left. This was done, we did this together in the early 2000s, and based on some work that we did here locally, looking at really, to be completely honest, what we were seeing is patients without a binder in place that would bleed to death routinely in our emergency department, and this led to work to develop the pelvic binder now over 20 years ago. Now, a couple of other advanced maneuvers that I'll just tell you are worth knowing. Where are we with these? So the one is Reboa, and the Reboa catheter, you've all seen this, where you place a Reboa catheter through the femoral vessels into the abdominal aorta. There was actually great hope that the Reboa catheter may be particularly helpful in patients with pelvic trauma because you could place the Reboa in zone 3 down here low and actually maybe attenuate some of the bleeding. As we'll see in a moment, the literature on Reboa really is not supporting the routine use of this approach because of, I would say, actually worsened mortality. And we could talk about that in another session, but the most recent literature would not support the routine use of the Reboa catheter. There's also an intervention that will be done by trauma surgeons, which is pre-peritoneal packing, where you can place packing in front of the pelvis. This obviously will be done in the operating room to compress the pelvis and also attenuate bleeding into the pelvic cavity. And lastly, an intervention that we all should be quite familiar with, and we should hopefully will have access to here very rapidly at CMC, is pelvic embolization, where you can actually put coils, vascular coils, into the pelvic vessels that are bleeding. And I would say, again, if you're a sender, getting your patient to a center that has access to immediate embolization, angioembolization, and interventional radiology is crucial. And we've made over the past few years, as Dr. Christmas will say, we've made major strides in getting earlier access to embolization, working very closely with our radiology department. And again, the literature on these 3 interventions kind of goes like this. Angioembolization is probably the most important intervention to reduce mortality if there is active extravasation on CT or if the patient is hemodynamically unstable. Pre-peritoneal packing is another important intervention that can be employed by the trauma surgeon. And unfortunately, there is a growing body of literature that would really question the use of Reboa routinely in unstable patients. This is another algorithm that I think is also important on the front end, because remember that, as I mentioned, these injuries do not occur in isolation. And it's also very important, for example, if the patient is leaving the ED and going for embolization, it's very important for us to understand if the patient may have, for example, a splenic injury or a liver laceration that is coincident with their pelvic injury that may require that the patient travel to the operating room. And this algorithm was developed by the same team that invented the binder 20 years ago, where we used either a diagnostic peritoneal aspirate and later, more recently, the FAST exam to really triage these patients to the right place. So the punchline here is, if you are hemodynamically unstable with a significant pelvic injury that requires intervention, and you have either a positive FAST or gross blood on a diagnostic peritoneal aspirate, your first stop has to be the operating room for an exploratory laparotomy. Conversely, if you have either a negative diagnostic peritoneal aspirate or a high quality FAST that does not show any evidence of free fluid in the abdomen, those patients would proceed for angiography, further stabilization and angiography. Stated simply, we don't want to go to the wrong place in a patient who has a pelvic injury, for example, but also has an abdomen full of blood. So this algorithm developed here at CMC can also help us decide where it is that we want to go. So let's keep going here. So this is case number 1. I'll just summarize this case. Remember that the structural integrity of the pelvis is extreme, and therefore, if the pelvis is pulled apart, you should be thinking about significant energy transfer, significant morbidity, and even lethality of these injuries. So quick action is extremely important. You should know your injury classification, begin resuscitation immediately to prevent the patient from further decompensation. Early pelvic stabilization is very important. Finding other injuries, mobilizing angio early, and then understanding whether or not the patient needs to go to the operating room. So that's case number 1. I'll probably hold questions till the end, and now we'll go on to case number 2. And this is a patient who has traumatic brain injury, a 25-year-old who was struck in the back of the head with a pipe. Remember, TBI is the #1 killer in trauma. He's found face down by paramedics in a pool of blood. He's not responding well. So his Glasgow Coma score is 10. And there you can see his vital signs demonstrate tachycardia, with a blood pressure of 95/69. And this is extremely important that he's, again, at risk for shock and at risk for significant consequences in the setting of a traumatic brain injury. His initial GCS, as mentioned, is 10. So the team begins to resuscitate him, and he moves quickly to the CT scanner for continued resuscitation and evaluation. And here's the injury that you find. So this patient has a left temporal epidural hematoma with some midline shift. And when he returns from radiology, you can see there that he is more somnolent. His GCS is now 8. And of high importance, his blood pressure and his heart rate are not going in the right direction, and he has a shock index of 1.1. So the question now for this patient who was assaulted with an epidural hematoma and vital signs that are problematic, what is the team going to do? Again, an epidural hematoma with that lenticular appearance that we're used to looking for. So here, remember that when we talk about shock in the trauma patient, again, when I was a resident 35 years ago, 90 was the number, and we know better now. We know that 90 is not the right number, and I would say in a young patient I would say, let's say I'm 64, so we'll say younger than Mike, I would use anything less than 110 is considered shock. And then Mike's age or older, anything less than 120 or 130 is considered shock in the older patient. And also the use of a shock index is extremely important in this case, because we know if somebody's shock index, remember shock index being heart rate over systolic blood pressure, if it's greater than 0.8, so it's less than 1 and approaching 1, then that is really a predictor of bad outcomes. And we'll go back to our patient who has a shock index of 1.1. So again, greater than 0.8, and this is a high predictor of post-intubation hypotension. That was actually work done in our hospital by Dr. Alan Hafner years ago. So be on the lookout for vital signs that are abnormal, be on the lookout for a fast heart rate, and be on the lookout for a shock index of greater than 0.8. So what actions are the team going to take now? And this is a study this study was published the year that I finished my training, so many years ago, but I think that the results of this study still hold true today. And in this study, they looked at 717 patients with severe traumatic brain injury, so a GCS of 8 or less, and remember, our patient had a GCS of 8. And what we learned from this study that was done in 1993 is that a single episode of hypotension or hypoxia in the emergency department, even if that was brief, resulted in an increase of mortality of 150%. So this is really a landmark study that teaches us that in the patient with traumatic brain injury, it is absolutely critical to avoid hypotension and hypoxia in the early phases of resuscitation. So really, this is our prime directive in a patient with TBI, is to maintain perfusion and oxygenation of the brain at all costs. And therefore, in this particular patient, our team will have to begin hemodynamic stabilization. We'll have to, obviously, this patient is going to require intubation, but we need to be very thoughtful about that, because we know that a patient on positive pressure ventilation can become hypotensive, and then we've broken the rule. We broke our prime directive, and the patient became hypotensive or hypoxic. We'll talk about hyperosmolar therapy, and obviously, urgent neurosurgical consultation is important. So when it comes to intubation, I think what we're seeing in trauma in particular over the past 5 to 10 years is we've moved away from a traditional airway breathing circulation paradigm to a circulation airway breathing paradigm. So resuscitation first before the patient is intubated. The reason for that is we know that a combination of positive pressure ventilation and the vasoactive drugs that we give to the patient can cause dramatic decreases in cardiac output, and then the patient will break the rule. So we'll violate the rule, we'll violate our prime directive, and the patient will become hypotensive. And we must avoid this at all costs. Remember the study from 1993, 150% mortality. So if I'm at the head of the bed with our team getting ready to intubate the patient, I'm going to ask for 3 minutes from the team at large to give blood, give crystalloid if you don't have blood. You may even start norepinephrine. We'll talk about that in a minute, or a combination of these things before intubation. So remember, resuscitation first, CAB rather than ABC. The goal is to maintain perfusion of the brain. And there are a number of studies out there, and this one is probably the best study that was done by the East Group that looked at several different trauma centers, international trauma centers, And they compared 24-hour mortality when a CAB approach was used versus an ABC approach. And you can see there that the 24-hour mortality in these patients was profoundly reduced from almost 70% to roughly 10% by resuscitating the patient before endotracheal intubation. And there are a number of studies out there, but I will tell you that the punchline here is that a resuscitation first strategy in trauma patients is associated with better outcomes. Now, I'll tell you, practically speaking, what this means is time. If you have a patient who is altered with a GCS of 8, or we may be cognitively pushing ourselves for intubation immediately, so you may need to hold back and understand how much time do you have, how much resuscitation can you get into the patient, how much time are you willing to wait in a patient with an unprotected airway. So this is not necessarily not necessarily a comfortable place to be, but I think if your team is well organized and they know the approach that should be taken, you can aggressively resuscitate the patient on the front end. It's not always going to be easy, but we know that if the patient becomes hypotensive, their mortality is going to go up. There are a number of different guidelines, and I'll run through these. Again, these are emergency medicine, critical care, and anesthesia guidelines. We know, again, that the vascular effects of these medications and positive pressure ventilation can cause cardiovascular collapse. We know that pre-intubation hypotension is associated with poor outcomes. We know that the risk is increased in a shock index of greater than 0.8. We know that fluids before intubation are critical. In the case of a trauma patient, that would also include blood. We know that vasopressors may be indicated to stabilize the patient before endotracheal intubation. We know that if you're talking about induction agents, I would say limit your choices to etomidate and ketamine, or ketamine rather. We know that fentanyl, midazolam, and propofol are associated with a very high incidence of post-intubation hypotension. So these drugs need to be avoided. And then, so again, the choice is simple. If you're going to induce your patient, you want to stick with either etomidate or ketamine. Now, I know that there's a lot of literature out there about one drug versus the other, but the punchline there is there's no proof supporting one or the other. So I would say use what you know, choose the drug that you use every day. If you're an etomidate person, go with etomidate. If you prefer ketamine, then go with ketamine. But the important comment here is you want to avoid propofol, midazolam, and fentanyl because of the much higher incidence of post-intubation hypotension. Okay, let's talk about hyperosmolar therapy. And to me, this has always been very interesting that, again, remember we said traumatic brain injury is the #1 killer in trauma, but yet the literature on hyperosmolar therapy is actually, I would say, very limited. In other words, there are not a large number of definitive studies, but the question is, what are you going to use? Are you going to use hypertonic saline or mannitol? There are several systematic reviews that have looked at this, and these have tended to favor hypertonic saline over mannitol because you achieve goal a little bit more rapidly and you have longer protection of high intracranial pressure. I would say the best study that's been done on this was actually done in children and published a few years ago in JAMA, and they looked at a pretty large population of pediatric patients with significant TBI, and they found that hypertonic saline outperformed mannitol with regards to ICP reduction. So in my simple brain, I stopped thinking about this a while ago, and I have moved entirely over to hypertonic saline because I also think, by the way, that it tends to support blood pressure a little more effectively than mannitol. So if you have access to both, my advice to you based on the literature is to use hypertonic saline rather than mannitol. With regards to hyperventilation, remember that the indications that are published by the Brain Trauma Foundation are very narrow, so we want to avoid hyperventilation when possible, because we know when you hyperventilate a patient, that will definitely decrease your ICP, but it does so at the expense of cerebral perfusion. And as we talked about several times, we want to maintain perfusion of the brain. So I would say hyperventilation only after other measures, aka hypertonic saline, and only for brief periods of time, perhaps on the way to the OR in the patient that has a massively asymmetric pupillary exam. A brief period of hyperventilation would be permissible, but I would say this should be very, very limited, and the BTF guidelines would say only consider with pupillary asymmetry, motor posturing, or rapid decline. And then when it comes to the removal of an epidural hematoma, we don't need to go through this in detail, but the neurosurgery guidelines call for, when it comes to decision making about the removal of an epidural, it involves the amount of shift, the hematoma volume and thickness, and also clinical features and the patient's presenting GCS. So in our patient who was assaulted, you can see on your left the CT scan that was done on the day of injury, the image in the middle, which are brain windows postoperatively, and this patient actually had a very significant full recovery after the early evacuation of the epidural hematoma. And there you can see the bone windows on the right, where the skull is placed back after removal of the epidural. So for severe traumatic brain injury, I just want you to remember the prime directive. Everything that we do in these patients should be guided to prevent hypotension and hypoxia. Obviously, physiologic optimization before intubation, careful use of your drugs, sticking with ketamine and etomidate, avoiding drugs that can cause hypotension, early hyperosmolar therapy, preferentially using hypertonic saline, and then, of course, early consultation with neurosurgery. And if you're going to be transferring the patient to a trauma center, getting that underway as quickly as you can to allow for the patient to have surgical evacuation. Okay, and we'll skip the question part. Let's go on to case number 3. This is a patient I actually took care of some years ago. She, a young woman who was in her car going to work on a Monday morning, and her car was struck on the side. And you can see there that she was also tachycardic. She was tachypnic and uncomfortable, complaining of a lot of chest wall tenderness. She was alert, moving all 4 extremities. And here is her pelvis x-ray. She also had a negative FAST. And here is the patient's chest x-ray. And what we can see here is the patient has a significantly abnormal mediastinum. Right now, what we'll do is we're going to talk about the x-ray findings and the CT findings of traumatic aortic injury. And in her case, what was super helpful is we went back and looked at an x-ray that she had had 1 year prior. So this is the same patient. On your right, the patient that we took care of on a Monday morning. And on the left, this is an x-ray that she had in my emergency department about a year prior. And I just want you to look here and compare the imaging of the mediastinum on the left and the imaging of the mediastinum on the right. Again, pre-injury pattern, post-injury pattern. Now, as we walk through this, what I want you to do is just look at the normal film, and I'm going to outline this for you now. And by the way, the one thing about aortic injury that is worth mentioning is that now, with improved vehicle safety and improved airbag design, the number of aortic injury has gone down precipitously. So back in the olden days when I was a resident, we would see these at the University of Pittsburgh, a level 1 trauma center. We would see aortic injuries every week. Now we see them much less commonly. So that means that we all need to be very astute detectives when we're looking at these x-rays to see whether there are abnormalities that would speak to an aortic injury. So let's go ahead and outline this normal x-ray, and we'll just follow the cursor. I want you to start right up here at the top of the aortic arch, the thoracic aorta, the normal thoracic aorta. You can follow it down here across the thorax into the abdomen, and right here, the junction between the thoracic aorta and the left heart border, this is called the aortopulmonary window, and I want you to follow the cursor. So the normal projection is down and out, down and out. That's normal. When you have reversal of that, where you have bulging of the thoracic aorta to the left, and you lose this down and out contour, that is the most important finding of an aortic injury. So not only the widening of the mediastinum, but also the contour of the thoracic aorta. We should be keenly interested in looking at that in a patient with this mechanism who's complaining of chest pain when we first see them. And again, here was her CT scan of the chest. You can actually see contrast that was extravasating from her thoracic aorta. So she was actively bleeding intramediastinum. And again, this was a Monday morning case. Everyone was there. The patient went expeditiously to the operating room, and she had, this is a bit of an old image, but you can see here the sheath, the endovascular repair that is going up into her thoracic aorta, and she actually did quite well and was discharged from the hospital 3 days later. Now, let's look at these imaging findings in more detail, and we'll talk about, again, some guidelines for imaging of the thoracic aorta. Remember, again, that there are several different mechanisms that have been proposed, and I think about this very simply. If I crash my car into a pole, at the moment that the car strikes the pole, the car stops, I'll stop, and my aorta will keep moving for a split second, and that puts a shear type force on the aorta that's going to cause it to tear, and it usually tears up here at the isthmus right here, high up in the thorax. So when we talk about imaging of looking for aortic injury in acute chest trauma, there is something called this is the Nexus chest CT criteria that were developed, looking at a number of different criteria. They are listed here, and what they found that in patients that had none of these criteria, this was 100% sensitive and specific for ruling out aortic injury. So very high, the Nexus decision rule, very, very high accuracy, looking at a large number of patients in ruling out aortic injury. And again, I'll show them to you here. So you need to be thinking about a rapid deceleration, chest wall tenderness, sternal tenderness, thoracic tenderness, or scapular tenderness. So punchline here, in a patient with a high injury mechanism that has tenderness of the torso, of the chest, be thinking about the thoracic aorta. If they, of course, an abnormal chest x-ray would be an important clue, or if they have a distracting injury that's going to prevent them from providing you with a reliable exam. Again, let's go back to our patient. This is the same patient, and we published this some years after that. And I want you to, again, in all the images that I'm going to show you, we have her pre-injury chest x-ray on the left and her injury chest x-ray. I'm sorry, let's flip that. Pre-injury chest x-ray on the right, injury chest x-ray on the left. Here we can see, again, mediastinal widening that is abnormal. Here we can also, and again, a normal mediastinum right here compared to the injury chest x-ray. We also talked about the contour of the thoracic aorta, and here we have an abnormal contour. We have loss of the aortopulmonary window compared to her pre-injury chest x-ray, where the aortopulmonary window is preserved. Now, what I'm going to do now is look at this x-ray. This is probably of the x-rays I've collected, one of the most dramatic chest x-rays I have in my collection, and it shows all the findings of an aortic injury. We're going to walk through these one by one. So, wide mediastinum, contour, aortopulmonary window, tracheal deviation, depression of the left main stem bronchus, apical cap, and deviation of a nasogastric tube. And this patient has all of them except for number 7. So, the mediastinum is wide. There is significantly abnormal aortic contour, so we lose the aortopulmonary window, and instead it bulges out. There's also, so right here, this looks markedly abnormal, and here you can see again the abnormal contour of the thoracic aorta. You can see also tracheal deviation, so the trachea is pushed to the opposite side by a mediastinal hematoma. There is also depression of the left main stem bronchus right down here. This should actually be at a more acute angle, but we can see it's being depressed here. And here you have a finding that is not common, which is called an apical cap. And what you see here is that this particular line, this outlines hemorrhage at the apex of the left lung. So blood that is dissecting up to the apex of the left lung. That's called an apical cap. And in this patient, I'll just show you, this is a patient with an aortic injury. This patient actually had a lawnmower that rolled over onto his chest. He had a nasogastric tube put in here, and you can see that it's pushed way over to the right. So for this injury, just focusing on the imaging, I would say be on the lookout for aortic injury, because these injuries are not as common as they used to be. Know the chest x-ray findings, know the Nexus criteria, which again, significant torso tenderness, distracting injury, major mechanism, and an abnormal chest x-ray. If you have those, you should be thinking about a chest CT to rule out an aortic injury, and those criteria are highly sensitive to do exactly that. Now, with the last comment that we don't have quite enough time to talk about here is that remember that the typical approach at a trauma center, let's say, for example, if this patient also has a ruptured spleen, we will typically recommend that active bleeding is controlled first, or if this patient had an epidural, like patient number 2, that we would evacuate extraaxial masses in the brain. So if the patient needs a neurosurgical procedure or if the patient needs a laparotomy, that will be done first before the aorta is repaired, and the aorta will follow once hemorrhage has been controlled and neurosurgical lesions have been evacuated. So we'll go on to the last case that I just snuck in there, which is an ATV crash. This is a patient that has a splenic injury who comes in after an ATV crash with abnormal vital signs, tachycardia, relative hypotension, left-sided chest wall tenderness. Always be thinking about the spleen in a patient that has tenderness, especially to the left lower chest, the lower ribs, because they are directly over the top of the spleen. Be thinking about splenic injury with lower chest wall tenderness. Our patient had abdominal tenderness and guarding. And again, normal x-ray here, normal pelvis x-ray, and here is your fast examination. I'll just show you your landmarks. Here's the left kidney right here. The spleen is above it. And this interface where you see black, this is actually blood in the splenorenal space in a patient that has a splenic injury. And this patient went on to have a CT scan of the abdomen. You can see here that the spleen is almost ripped in half. And also of importance, what you see is contrast extravasation. So this, for the emergency physician or the trauma surgeon or whomever is taking care of this patient, whether it be an APP or a physician, it's very important to clue in on this to see that this patient has active extravasation. And that's called, the simple term that even Mike can remember, is a contrast blush. And this patient also has a very substantial amount of free fluid in the pelvis that is outlined here by the asterisks that you see. So relatively unstable patient with abnormal vital signs, high injury mechanism. The spleen has a significant laceration that goes right through the hilum with active extravasation. So this is a patient that needs to have immediate action. And the patient went on, this injury occurred at our center, and the patient went on to have, the patient was stabilized in the ED with some resuscitation and then was stable enough to go for angioembolization. And here you can see on the same patient, this is actually extravasation of blood into the spleen from 2 different locations. And here you can see angioembolization with a coil placed and the bleeding interrupted. So whenever possible, in the patient who is not persistently in shock, who needs a laparotomy and a splenectomy, we will try to optimize the patient for angioembolization and splenic preservation. I would say that becomes doubly important in children, where angioembolization is always preferred. Again, if the patient is in profound shock, they need a splenectomy with no delay. Now let's just look at some other cases. And again, this is background. The spleen is the most commonly injured intra-abdominal organ because the spleen is mobile and it's exposed. Your physical exam should focus on the left lower ribs as well as the left upper abdomen. And a patient with blunt trauma who has lower rib tenderness, about 10% of them, if they have a significant mechanism, will have an injury to the spleen, especially if the patient has pleurisy. That patients who complain of pain when they take a deep breath, that is also a marker of a splenic injury. And remember, Kerr's sign, which is caused by blood under the diaphragm, is going to give the patient left shoulder pain. And that can also be an important clue in a patient with an injured spleen. There's a grading system that is available for you to know. But I would say most importantly, rather than knowing the grading system, that trauma surgeons use every day, and we in the emergency department here at CMC have some facility with. Rather, I think looking at the CT scan and understanding these are 3 different cases in a patient that has a contrast blush. So there's a blush here, there's a blush here. Again, 3 different examples of contrast blushes, and that really is what you need to be cluing in on. Does this patient have evidence of active arterial extravasation, and what are we going to do about it? So there are a number of algorithms that have been published. This was published by the by the World Society of Emergency Surgery, and these are complicated, so we don't really need to go through this. But in my brain, really, I think splenic injuries represent a continuum when it comes to management. So stable patients, with no contrast blush and no other indication for laparotomy. These are the patients that can be observed overnight or perhaps for a few days until they stabilize. So this would be your observation group. Patients that have a contrast blush, but who are stable and have no other reason to go to the operating room, so no other associated injury, for these patients, angiography would be prioritized so they could have splenic preservation. And of course, a patient who is persistently in shock with a splenic injury, especially with a contrast blush, these patients should be going for splenectomy. The one comment that I'll raise, for the reasons that we mentioned earlier, any patient that has a coincident traumatic brain injury, I would say that the cadence of resuscitation and the steps taken to actually go up a notch when it comes to definitive management are important. So remember that these patients with TBI will not tolerate hypotension. So this may mean either more aggressive angiography, more aggressive resuscitation, or earlier splenectomy to prevent hypotension for the reasons that we mentioned earlier in this talk. So these patients are very high risk. And we'll finish up by looking at some cases from CMC, and again, some CT cases from CMC. This is a patient who was in a motorcycle crash, and again, high velocity mechanism, unprotected trauma. Motorcycle crashes are quite morbid. You can see here contrast blush on the coronals and also the axial view. This patient went on to, this is the angio on the same patient. Here you can see extravasation, and the patient went on to have another coil. Here's another case that we looked at the CT scan a minute ago, in a patient with an arterial extravasation here, visible on all these views. This patient went on to have coiling as well. We're almost done, by the way. We'll have a couple minutes for questions. Another one here is a little bit more subtle. You can see the extravasation right here in a splenic injury, also a motorcycle crash. This patient also went on for coiling. And the last one here, again, another patient with a significant kind of scattered extravasation, and this patient also went on to have angioembolization. So for splenic injury, again, this is the most commonly injured abdominal organ in blunt trauma. Your fast exam is absolutely vital. I would say when you have suspicion, you should proceed rapidly to CT imaging. Be quick to evaluate those images, looking for a contrast blush. And then when it comes to the continuum of management, here again, whether it be observation, angiography, or operating room, this is going to be a team decision between the trauma team and the ED and the transferring center and the receiving center. So having high collaboration here is always important. Now I will stop for questions here. I'm going to unshare my screen, and I'll take any questions that folks have, whether you want to put them in the chat or just speak up. I'll be watching the chat here and happy to answer any questions in the next few minutes.
That was incredible, Dr. Gibbs. I'll start us off with a question. Regarding the avoidance of hypotension and TBI, you mentioned earlier the lethal triad, and we all know that crystalloid in trauma is bad due to the coagulopathy, hypothermia, and acidosis. Are those same concerns present in TBI when using saline?
I would say generally yes. So this is going to be the answer is complex because it's going to depend on what you have available to you. So for example, if you're a paramedic and there's no blood in your rig and the patient has problematic vital signs and a traumatic brain injury, I would absolutely give them crystalloid on the front end to try to increase their intravascular volume. We know that it doesn't do it as well as transfusion, but I would say normalization of vital signs with crystalloid when you don't have blood available is essential. And then when you arrive at either a community hospital or trauma center, then that team, recognizing the TBI and recognizing, for example, an abnormal shock index, should transition rapidly to blood. You may not be able to do that immediately. Here we have blood in our trauma room, so it's a lot easier for me to reach over and grab that quickly, which I will do immediately in a patient that has abnormal vital signs and a GCS of less than 8. But I would say the punchline, do what you can, crystalloid or blood, prioritize early transfusion, whole blood or one-to-one transfusion strategy. Great question.
There's a question in the chat. Is the spleen algorithm different for pediatric patients? Not all blushes get intervention.
Yeah, so Dr. Cosper, I would say Dr. Cosper is actually the expert as a pediatric surgeon. So I would just say in somebody that has a blush who is, so my typical practice or my typical understanding of someone who has a stable patient with a blush on CT scan, that at least what I want to do is I want to prepare that patient to be able to have an angiographic intervention, which means engage angiography early. Now, if the patient stabilizes, perhaps maybe that can be watched and delayed. I would say typically in that case, if you take large populations of patients with a contrast blush, a significant percentage of them will ultimately go to angiography. So the key thing is not to cause delays. And I'll be very transparent. We looked at this, Dr. Christmas looked at this in a very skilled fashion about 5 years ago. And we noticed at that time that we were experiencing significant delays to get to angiography up to 4 hours. And since then, there was tremendous work done, both with children and adults, to engage in angiography earlier and to really have our radiology team respond. And now I can tell you that our times to angiography are very quick. But remember that the team in the trauma room should be thinking about that and at least notifying the right radiology squads to make sure that we have the option of using angioembolization. That was kind of a circuitous answer for Dr. Crosper for me saying, in children, I don't know exactly when a blush how you would bracket those patients into angiography or no angiography. We have time for a few more comments or questions.
Any questions from the audience? I have another one if there isn't one.
Yes, sir.
You sort of answered this one towards the end of your presentation, but pre-hospital ultrasound was just approved as part of EMS scope of practice. And as you know, FAST exams are a very common exam in the ED. Do you foresee or do you currently see these aortic and spleen injuries you're talking about showing up more frequently on ultrasound, or do you need that CT imaging you referenced? And then will this change treatment practice prior to arrival at a trauma center?
Yeah, I think that's a great question. So I think in my view, the benefit of ultrasound in the pre-hospital setting is going to be to do two things. One is and by the way, I think especially when providers, I say paramedics or residents or attendees and even fellows, when we're learning ultrasound, we need to be careful about doing this initially as a rule-in study. So, for example, if you see free fluid in the abdomen and you rule in hemorrhage, therefore, that's a call that you can make early in your journey learning ultrasound. But to use it as a rule-out study is a little bit trickier, and that's going to take a lot of experience and time with the machine. I would say in the field, the two indications that I would see would be the most beneficial would be ruling in a pneumothorax with looking at lung sliding and examining the torso, and the second would be ruling in free fluid in the abdomen. If you see obvious fluid there, it may do a couple things. It may escalate your resuscitation in the back of an ambulance. It may provoke you to go to another center. It may provoke you to notify the receiving center early to get the team ready if you have a FAST exam that demonstrates abnormalities. So, I would say that I continue in my practice to do ultrasounds as often as I can when I'm helping take care of injured patients, because I think this is a skill that requires very high and thoughtful skill maintenance to develop expertise.
One of our Med Center Air friends agrees with you in the chat.
Yeah, we of course look forward to the proliferation of this technology into the field. I think will be a very positive step, but I would say very thoughtful education and skill maintenance is going to be critical, as you all know.
And I just had one sent directly to me. Other than recognition and rapid transport or transfer of a pelvic fracture, what is the top intervention for EMS or a referring hospital that's not a trauma center?
Yeah, so this applies, by the way, to the field, and we did some work with MTAC looking at pre-hospital pelvic stabilization. I think in a patient who you think is at high risk, that may be a patient, for example, remember, there are two things that Satan created: motorcycles and tequila. So if it's a motorcycle crash, especially if the patient has pelvic tenderness, I think the paramedic team should consider the application of a pelvic binder. Certainly at hospital number one, if you get an x-ray that looks like some of the x-rays that we looked at together, I would say that would be an indication for immediate application of a pelvic binder. And remember, when you looked at our patient, the difference in pelvic geometry that happened after the application of the binder. The second would be recognition that in a patient with pelvic trauma, that there's a very high risk of hemorrhage, and therefore immediate resuscitation, whether it's with crystalloid in the back of the ambulance or with early use of blood in, early, if you're at hospital number one, is going to be really important. And the question here, I would say preferred sedation. I would say, so the other thing is, I would say analgesia first before sedation. I would say probably small doses of fentanyl, I think, are appropriate. If the patient's in profound shock, that's obviously going to be out. But I would say titrating small doses of fentanyl first would be a good idea. If you're sending the patient, I would be very careful. For example, an intubated patient with marginal vital signs, I would be very careful with propofol. That doesn't mean no, but it means be careful, because again, we have to maintain perfusion and have adequate resuscitation. So, in our emergency department, we will, if the patient has marginal hemodynamics, we will typically wait to start the propofol until they've been stabilized a bit more. And then we will use incremental doses of whatever it is that we choose, always watching the patient's hemodynamics.
Excellent. Any other questions? We've got some good ones in the chat. And just so you know, Dr. Gibbs, it was just sent to me again directly that I sold my motorcycle, but you better keep your hands off my tequila.
Fair enough. The lesser of two evils, baby.
Any other questions?
Always a pleasure to meet with this group. Thank you for all that you do, as part of our system to really provide great trauma care across this region. We wouldn't be able to do it without you. We're very heavily reliant on your strong instincts, your early intervention, your patient stabilization. Deciding again, as we talked about when we opened, which patients require immediate action, which patient require early transfer, and by doing this together, there's no doubt that the outcomes of our patients are profoundly improved by what you do before the patient ever reaches CMC. So thank you. I would say thank you always for what you do.
Thank you, Dr. Gibbs. And with that, I appreciate everybody being here. Be sure to take note in the chat the evaluation link, as well as the mention of our upcoming symposium on May 14th and 15th. Thank you, everybody.